Sure. My name is Tom Smith. I'm a medical oncologist. I work at Virginia Commonwealth University's Massey Cancer Center in Richmond, Virginia. My colleague Bruce Hillner and I just published an article in the New England Journal of Medicine as a sounding board called Bending the Cancer Care Cost Curve. One of the reasons for this topic being so timely is that the cost of cancer care is projected to rise from $100 billion just a few years ago to close to $200 billion in just 10 years. Some of the reasons for that include the fact that there are more of us, and we're getting older, and there's more treatment being delivered to each of us during our illness. That plus the rising, almost exponential cost of these medicines makes a problem that's simply unsustainable in its current way. So we have to think about some way to reduce the cost of cancer care while maintaining the quality. Sure, right now oncology drugs are second to cardiology drugs, partly because cardiology drugs are taken for such a very long time. I think that's likely to change with the introduction of some new, very expensive cancer medicines. We're used to paying $3,000 to $6,000 every month for cancer medicines, but there are two medicines coming on the market. One is called Provenge for people with prostate cancer. The sticker for that is $90,000. Another one is for metastatic malignant melanoma. 4 treatments, the company will charge $120,000 for those 4 treatments. That's just the tip of the iceberg for a lot of new cancer medicines that will actually work and most people will desire. So we have to figure out some way now to reduce the cost of what we're doing in order to make room for some of these new medicines. Sure, oncologists have a unique part of their practice in that we make money, some of us, by buying and selling the drugs. That didn't arise out of any nefarious plan. It just grew because nobody else wanted to take the risk of having these medicines. And that's become a way for oncologists to have substantially higher incomes than other internal medicine specialists. Up until 2 years ago, oncologists were the most highly paid medical specialty. That's dropped off substantially in the past 2 years, and I anticipate it will drop even more in the next 5 years. But we're still very well paid compared to people in, say, family practice or general internal medicine. My colleague Bruce Hillner and I have outlined 5 parts of medical care that are under oncologist control where we can make changes fairly quickly. We also went on to outline 5 steps that society will have to take in order to help ultimately bring down cancer care costs. But there are at least 5 things that are under oncologists' direct control. No, there are 5 things that cancer doctors like me can do to help reduce costs right now. The first of these is relatively simple and is very much evidence-based. It's endorsed by the American Society of Clinical Oncology and the National Comprehensive Cancer Center Network. That's to limit surveillance testing after curative care to those tests and procedures that we really know work. We can use breast cancer as an example. When last tallied about 15 years ago, the United States alone spent about $1 billion on follow-up testing for breast cancer patients on a regular schedule, as opposed to when patients began to have symptoms. Now, there have been several randomized clinical trials done in Europe that showed that actually didn't make a difference, that the great majority of women with breast cancer actually won't have a recurrence, that about 85% of recurrences don't happen on that scheduled visit, but are in between and are reported by women in between, and that the type of recurrences that the tests we have pick up don't lead to finding more curable disease. What's really important is to make sure women get mammograms, make sure women report any symptoms. In my own practice, I really stress losing or maintaining weight, exercising, eating a better diet, getting help with psychosocial stress, all the survivorship issues that typically are not stressed so much in oncology practices, but not doing PET scans, CAT scans, bone scans, liver ultrasounds, blood tumor markers. All of those tests have been shown not to be very helpful in detecting cancer recurrence and leading to more cured people down the road. This is very specific to each cancer. Testicular cancer, for instance, it's critically important that people follow a rigid schedule of testing to find recurrences when they can be cured. The great majority of solid tumors like breast cancer, lung cancer, pancreas cancer, etc., There's no proven advantage to doing surveillance testing on a regular schedule. So let's bring those patients in for visits. Let's make sure they're doing well, but not spend billions and billions of dollars on tests that aren't going to help anybody. Another area where the experts agree is the use of single agents rather than combination therapy for people with metastatic solid tumors. Again, this is very disease specific, but just using breast cancer as an example. Unless somebody's very symptomatic or in crisis, a single drug will have just the same amount of effectiveness in prolonging that person's life as giving 2 or 3 drugs in combination. A single drug is far less toxic, extends life just as long, doesn't require as much supportive care, which can be really expensive, like filgrastim and erythropoietin drugs. So you get just as much benefit in terms of prolonging survival, you get just as much improvement in quality of life, but you do it with far less toxicity, far fewer hospitalizations, particularly towards the end of life, and at a lot less cost. That again is money that can be saved and used for some of the newer, more effective drugs coming down the pike. The third part that's directly under oncologist control is to limit chemotherapy to those people who are likely to benefit from it. One of the easiest ways is to tell if the patient is able to walk into the clinic. This is a point that my colleague Dr. Bruce Hillner raises. If the patient has difficulty walking unaided into the clinic and because they're weakened from their disease, that means their performance status is rapidly declining. That means they're not very likely to respond to the next line of chemotherapy if they have lung cancer, colon cancer, breast cancer, prostate cancer, etc. And all the evidence and all the evidence-based guidelines strongly support that. When a person's performance status is 3 or 4, they shouldn't be receiving chemotherapy. That's an excellent trigger point to start thinking about transitions towards palliative care and hospice. The fourth direct point under oncologist control is to limit the use of hematopoietic or white cell stimulating growth factors. These were important advances. They help people with lymphomas and other curable diseases get through their therapy. They're critically important to some types of breast cancer therapy given after or before surgery. But for the average person with metastatic solid tumor, such as colorectal cancer, prostate cancer, lung cancer, breast cancer, the big 4, they have not made an improvement in the overall survival from these diseases. They also cost a lot of money. The average injection may cost as much as $3,500. So we're asking, if you have $3,500 to spend, would you rather spend it on a new drug that actually treats the cancer? Or would you rather spend it on something that just supports the ability of the patient's white cells to recover a little bit sooner? And in most incidences, we have good evidence that you can simply reduce the dose a little bit or perhaps use prophylactic antibiotics to get the same effect from the same chemotherapy drugs. The fifth practice that's under the control of medical oncologists is to limit use of chemotherapy to those people who are likely to respond. This is a point that's been stressed by ASCO recently. If patients have very little chance of responding to chemotherapy, it's time to use that as a trigger point and make some transition points. Transition to non-chemotherapy-based hospice and palliative care. One of the easiest ways is to ask the recent history. If the cancer has grown on 3 successive regimens, the chance of it responding to a 4th, 5th, or 6th is vanishingly small, particularly if the person's performance status is declining at the same time. So that's a good trigger point when the cancer has grown through the 2nd or 3rd regimen to start bringing up discussions about end-of-life care, choices about mechanical ventilation and CPR, choices about where that person wants to spend the rest of their days, whether they want to be at home when they die. You don't have to necessarily give up on chemotherapy right that moment, but it's always a good trigger point to start the conversation.